Let's jump right into this explainer because we're tackling one of the absolute highest stakes differentials you'll ever face in GI and colorectal surgery. We're talking about mastering inflammatory bowel disease, specifically that razor-thin, knife-edge distinction between ulcerative colitis and Crohn's disease. When you're in an acute setting, nailing this diagnosis isn't just about passing your boards, right? It literally dictates life-saving rescue protocols and the exact timing for surgery.
Okay, so picture this. You've got a 28-year-old guy crashing in your ER. He's got a 3-week history of, say, 14 bloody mucopurulent bowel movements a day. He's miserable with severe tenesmus and diffuse cramping. You look at the monitor. Heart rate's 118, tempus 38.4 Celsius, and his hemoglobin has completely tanked to 7.6. Then you pull up a plain film of his abdomen, and there it is, a transverse colon blown all the way up to 6.9 centimeters, complete with mucosal thumbprinting and absolutely no hostile markings. At this point, the clock is officially ticking.
So, before you even think about grabbing a prescription pad or paging the surgical team, your brain has to snap to the ultimate question. You've got to answer this to save his life. Are we looking at acute severe ulcerative colitis, what we call ASUC, with impending toxic megacolon? Or is this a fulminant Crohn's colitis flare?
The reason we have to know right now is to avoid a massive surgical mistake. I call it the OR trap. If you rush this unstable patient into the operating room and try to do a primary pelvic dissection with an ileopauchoanal anastomosis, an IPAA, in the middle of this acute emergency, you are walking right into a total disaster. Doing a primary pelvic dissection in this setting carries a huge mortality risk, plus an over 50% rate of pelvic sepsis and ultimate pouch failure. Just don't do it.
To lock the difference between these two diseases into your clinical memory, I want you to think of the bowel wall like a house. Ulcerative colitis, that's a wall paint problem. It's strictly a disease of the superficial mucosa and submucosa. It starts right at the front door, the rectum, and just rolls continuously inward along the surface. It never skips a single inch, and it stays strictly confined to the colon. Crohn's disease, though? That is structural foundation damage. It's transmural. It burns right through the mucosa, the submucosa, the muscularis propria, and deep into the subserosa. It causes these deep linear fissures and patchy skip lesions scattered randomly anywhere from the mouth to the anus.
And all of that structural damage makes perfect sense when you look at the basic science driving it. On a microscopic level, UC is the superficial atypical Th2 response. It's driven by natural killer T cells pumping out IL-13, which gives you those classic crypt abscesses and goblet cell depletion. But Crohn's is a totally different beast. It's a transmural Th1 and T17 process, mostly driven by macrophages pushing out high titers of TNF-alpha. Histologically, you're going to see deep lymphoid aggregates and, of course, those hallmark non-caseating granulomas.
Now, stepping back from the bowel, it's absolutely crucial that we quickly identify extraintestinal manifestations. Things like primary sclerosing cholangitis, or PSC, that is strongly tied to UC, accounting for roughly 75 to 80% of PSC cases. And here's the kicker. It persists regardless of whether the colitis is active or not. On the flip side, in Crohn's, unabsorbed fatty acids in the terminal ileum bind to calcium, which leaves free oxalate floating around to form calcium oxalate stones. Oh, and if you ever see perianal fistulae or complex skin tags, that just screams Crohn's.
So bridging all this basic science back to the OR, if you build a nice new ileal pouch for a misdiagnosed Crohn's patient, guess what happens? That transmural Th1 inflammation will ruthlessly attack and destroy your pouch. You'll end up with pouch fistula and a patient with a permanent stoma. You have to always inspect for small bowel skip lesions, subserosal mesenteric creeping fat, and perianal fistula before you ever commit to a pouch.
Okay, let's circle back and build our diagnostic framework for that crashing 28-year-old we talked about earlier. He's got 14 bloody stools, a heart rate of 118, a fever, and severe anemia. Well, he perfectly meets the True Love and Wits criteria. You only need 6 or more bloody stools a day, plus just one sign of systemic toxicity. Since he has several of those signs, we can officially confirm his diagnosis as Acute Severe Ulcerative Colitis, or ASUC.
Once we have the diagnosis, we need to accurately stage the disease for long-term management. We rely on the Montreal classification for this. For UC, the extent goes from E1, which is proctitis, all the way to E3, pancolitis. For Crohn's, we stratify by 3 things: age, location, and behavior. So that's age from A1 to A3, location from L1 terminal ileum to L4 upper GI, and behavior from B1 non-stricturing to B3 penetrating disease. Plus, we add that really critical P modifier if there are perianal fistula. Alongside this, we use the Mayo endoscopic subscore to grade mucosal friability, and we look for a fecal calprotectin level over 150 to definitively prove there's active mucosal inflammation.
Right, so we have our ASUC diagnosis. Now the ticking clock of the medical rescue protocol begins. Day 1. You admit the patient to a colorectal or GI unit. You hit them with IV hydrocortisone every 6 hours. You also immediately start high-dose, low-molecular-weight heparin because these patients are at a massive risk for throwing a clot. And crucially, you've got to rule out C. diff and cytomegalovirus, or CMV, right away.
Fast forward to day 3. We evaluate their response using the Oxford criteria. If they're still having more than 8 stools a day, or even 3 to 8 stools but with a really high CRP, well, they failed steroids. And why does this specific timeline matter so much? Because a patient failing steroids on day 3 faces a staggering 85% risk of needing a colectomy if they don't get immediate rescue therapy. 85%! So what is that vital rescue therapy? You generally have 2 main options here, infliximab or cyclosporin. If we look at the landmark SISIF and Construct trials, they actually show that these 2 drugs have equal efficacy in rescuing ASU. There's really no significant difference in response rates or in avoiding a colectomy. Basically, your choice is going to depend almost entirely on your center's specific expertise and the patient's individual side effect profile.
But what happens if medical therapy just completely fails? If they fail rescue therapy by day 5 to 7, or if toxic megacolon rears its head, we have to pivot. We move straight to the modified 2-stage surgical strategy. Step 1 is an emergency, life-saving subtotal colectomy with an end ileostomy. Then we wait. Months later, once the patient is nourished, healthy, and entirely off steroids, we go back in for Step 2, the completion proctectomy with a J-pouch and a temporary loop ileostomy. And then eventually, we finish up with Step 3, the ileostomy takedown.
Now, pay attention to this, because it's a golden emergency surgical rule. During that initial, life-saving surgery, you absolutely must leave the rectal stump intact as a Hartmann's pouch. I repeat, do not perform a proctectomy. Trying to do a deep pelvic dissection in a septic, malnourished patient who is loaded up on high-dose steroids is just incredibly dangerous. Plus, leaving the stump preserves those delicate pelvic autonomic nerves, which protects erectile and ejaculatory function, and it gives you time to get definitive histopathology back before you try any elective reconstruction.
Let's layer in some senior attending wisdom here, things that can genuinely save your patient from major, life-altering complications. First up is the backwash ileitis trap. Keep in mind that up to 15% of patients with extensive UC will actually have mild inflammation in their terminal ileum. So don't let a little terminal ileum erythema trick you into diagnosing Crohn's if the rest of the colon is showing classic, continuous pancolitis. Second tip, always biopsy for CMV inclusion bodies and steroid refractory cases. And third, when you're finally creating that J-pouch down the line, you've got to carefully skeletonize the superior mesenteric artery origin. It's the only way to ensure a truly tension-free anastomosis.
Oh, and we have to talk about the bizarre cigarette smoking paradox in IBD. It is such a fascinating quirk of pathophysiology. It turns out, smoking and nicotine are actually somewhat protective in ulcerative colitis. Nicotine increases colonic mucin production and changes mucosal blood flow. But conversely, in Crohn's disease, smoking is highly toxic. It literally doubles the rates of disease recurrence, the need for surgical interventions, and biologic failure. Wild, right?
I'm going to leave you with a provocative scenario that shows exactly how missing one tiny, microscopic detail could cost a young patient their entire colon. Imagine that 28-year-old ASUC patient we started with. He failed day 3 steroids. The surgical team is already outside scrubbing in. But suddenly, the path report from the flex sigmoidoscopy pops up, and it's positive for CMV inclusion bodies. Do you still rush him to the OR for a life-altering colectomy? Or do you immediately start IV ganciclovir, treat the virus, abort the flare, and actually save his colon? The details absolutely matter. Thanks for joining this explainer, and make sure you keep these protocols locked in your mind for your very next shift.